language. I mean, just think about it for a second. It's absolutely fundamental. It's how we connect, how we learn, how we build. Well, everything, really, our whole civilization.
It really is. That ability to share complex thoughts using symbols is, uniquely human.
And what's fascinating, neurologically speaking, is that when this ability gets disrupted by brain damage, it actually gives us this incredible insight into how the brain works, how it organizes these really complex functions.
That's right. Analyzing language disorders was actually one of the very first ways we linked a specific higher cortical function language to damage in a specific part of the brain.
So it has this historical significance, too.
Absolutely. And even today, analyzing the specific way someone's language is affected can be incredibly useful for diagnosis. It helps us understand exactly what's going on in the brain, sometimes with surprising precision.
Like a map, almost.
Yeah.
Damage this area, and you tend to see these kinds of language problems.
Pretty much, yes. There are predictable patterns.
Okay, so for this deep dive, we're going to really get into the details of two major types of these language disruptions, aphasia and dysarthria. We've got some pretty comprehensive material here.
Yes, based on chapters 13 and 14 that we reviewed.
And our goal is to break it all down for you. We'll define the key terms, look at the brain mechanisms involved, and talk about how these conditions actually present in patients. We want to build a solid understanding.
Exactly. We're aiming for clarity, those kind of aha moments where you see the connection between the symptoms and the underlying neurology, but, without overwhelming you with jargon.
Perfect. So let's kick things off with aphasia. What exactly is aphasia at its core?
Okay, so aphasia is an acquired language disorder, and it results from brain damage.
Acquired. That's important, right?
Crucial. It means it's a loss of language function that someone already had. It's not like a developmental language issue that someone's had since childhood. This is a disruption to an established system.
Right. Something happens like a stroke or injury after language is already developed. And crucially, it's a problem with language itself. The symbols, the rules, the meaning, not necessarily the physical act of speech.
Precisely. Speech involves the muscles, the articulation, phonation. Language is the system. So someone with aphasia might have perfectly fine vocal cords, strong mouth muscles, but still struggle to find the words or string them together correctly.
Like the software's glitching, even if the hardware is okay.
That's a great analogy. The underlying program for language is disrupted.
So how is aphasia different from other things that mess with communication, like, say, dysarthria, which we'll get to, or even, thought disorders in psychiatry?
Good question, and it's a key distinction. Dysarthria is a motor speech disorder. The problem there is in the execution, weak muscles, poor coordination leading to slurred speech.
No.
Stuttering, voice problems, those are also motor speech issues. Aphasia is different because the core problem is with the language system itself finding words, grammar, understanding.
Makes sense.
Now, psychiatric disorders, well, they can definitely affect communication. Speech might be illogical, disorganized. But often, the basic linguistic structure, the grammar, the word formation, might still be technically intact. It's the content or flow that's primarily affected.
Right.
Though it's important to add that language problems in diffuse brain diseases like dementias or encephalopathies do count as aphasias, even though other cognitive functions are also affected.
Okay, so aphasia is specifically about that language system.
Right.
What are the basic building blocks of that system that can get disrupted?
Language is complex. You've got several layers. Phones, those are the basic sounds like B or P. Morphology, how words are built, like adding ed for past tense. Semantics, that's the meaning of words.
Okay.
Your mental dictionary, all the words you know, that's the lexicon. Syntax is the grammar, the rules for putting words into sentences. Discourse is how we string sentences together coherently, like in a story. And pragmatics is using language appropriately in social contexts, like knowing when to talk, understanding sarcasm.
Wow, a lot of moving parts.
And different types of aphasia can hit one or more of those components.
So where in the brain does all this happen? What's the basic neuroanatomy?
Well, when you hear speech, the sound goes through the auditory system to the auditory cortex in both temporal lobes, specifically Heschel's gyrus.
Right.
But the heavy lifting for understanding that sound as language happens mostly in the left, superior temporal gyrus and sulcus.
And that includes Wernicke's area.
Exactly. The back part of the superior temporal gyrus, that's Wernicke's area, critical for comprehension. Then for producing language, you've got Broca's area, down in the inferior frontal gyrus, also typically on the left.
And they talk to each other.
They do, through a big fiber bundle called the arcuate fasciculus. Think of it as the highway between comprehension and production.
Okay.
Then, to actually speak, the signal goes from Broca's area down the cortical bulbar tract to the brainstem nuclei controlling the speech muscles.
So it's a network.
Yeah.
But not just those two areas in the connection, right? Other bits must be involved. Yeah.
Absolutely. These core areas connect with other cortical regions involved in memory, attention, decision-making. And we're learning more about subcortical structures, too. The thalamus seems important for sort of alerting the language cortex and the basal ganglia for fluency.
It's all interconnected.
Highly interconnected. And yeah, for most right-handers and even many left-handers, the left hemisphere is dominant for language. That's why left-sided brain damage is the most common cause of clinical aphasia.
Okay, that gives us a good foundation. Now, what are some key symptoms we might see if someone has a language disorder like aphasia?
Well, one obvious one could be muteness, just not being able to speak at all.
But that doesn't automatically mean aphasia.
No, definitely not. Muteness can come from severe motor speech problems like anarthria or psychiatric conditions like catatonia or even physical issues with the larynx. A key clue for aphasic muteness is checking if they can still write or type coherently. If they can write normally, it's probably not aphasia. But if they can't speak or write meaningfully, and maybe struggle with comprehension too, especially with other signs of left hemisphere damage, then aphasic muteness is much more likely.
What if they are speaking, but it sounds off?
Halting, maybe.
Yeah, halting, effortful speech can be a sign. Again, it could also be a motor speech issue or even psychogenic. A useful check is, can you transcribe what they're saying into normal grammatical language? If yes, the underlying language might be fine, and the problem is more mechanical.
Okay.
In aphasia, that effortful speech might come from trouble initiating speech, articulating the sounds, building sentences grammatically, or just finding the words they need.
Which brings us to anomia word-finding difficulty. We all get that sometimes, the clip of the tongue thing.
Exactly. But in aphasia, anomia is much more frequent and severe. You see lots of pauses, maybe talking around the word circumlocutions because they just can't retrieve that specific noun or verb.
And then there are paraphasias. What are those?
Paraphasias are basically word errors. They can be literal or phonemic, substituting a wrong sound, like saying pable for table.
Okay. Or they can be verbal or semantic, substituting a wrong but often related word, like saying spoon for fork.
I see.
You might also see perseveration, getting stuck on a word or phrase and repeating it inappropriately, or neologisms, just completely made up words. And sometimes speech becomes jargon so full of errors it's just incomprehensible.
And it's not just about speaking right. Understanding language can also be impaired.
Absolutely. Difficulty understanding spoken language, impaired auditory comprehension is a very common feature of aphasia. Reading and writing are often affected too, though the pattern varies a lot depending on the type of aphasia.
So if someone is speaking fluently, but it's full of those errors, like jargon, what else could be going on besides aphasia?
That's a really important differential diagnosis. Fluent paraphasic speech is classic for certain aphasias, like Wernicke's. But you also have to consider psychosis, though often the grammar is more intact there. It's the ideas that are disorganized. An acute encephalopathy or delirium could also cause confused speech, but you'd usually see other signs like disorientation, agitation, maybe hallucinations. And then there are dementias. Language can break down there too, but it's usually more gradual and happens alongside decline in memory and other cognitive functions. Sudden onset fluent paraphasic speech, especially in an older person, strongly points towards a stroke causing aphasia.
Got it. So when a clinician suspects aphasia, how do they assess language at the bedside?
It really starts just by listening to their spontaneous speech during the interview, seeing how well they follow the conversation. You pick up a lot just from that natural interaction. Pauses, word errors, comprehension difficulties.
And then there's a more structured exam.
Yes, the classic 6-part bedside exam is really useful. First, analyze spontaneous speech more formally. Fluency, phrase length, grammar, errors, prosody. Second, naming. Ask them to name objects, pictures, body parts. Third, auditory comprehension. Give simple commands, close your eyes, then more complex ones, touch your nose, then point to the ceiling. Ask yes-no questions, maybe some absurd ones to really check understanding.
Like, does a stone float on water?
Exactly. Fourth, repetition. Have them repeat words, then phrases, increasing complexity. Fifth, reading. Both reading aloud and checking their comprehension of written material.
And sixth?
Sixth is writing. Get a sample of spontaneous writing, maybe ask them to write to dictation, and also copy some words. Writing can be very revealing, sometimes showing deficits you didn't catch in speech.
And the clinician puts all this together.
Precisely. They combine the pattern of language strengths and weaknesses from the exam with the rest of the neurological findings. Any weakness, sensory loss, visual problems. These associated signs are crucial for classifying the specific aphasia syndrome and figuring out where the lesion likely is in the brain.
Okay, let's get into some of those specific syndromes. Broca aphasia is probably the best known. What does that look like?
Broca's is the classic non-fluent aphasia. Speech is effortful, halting. They often produce short phrases, mainly using content words, nouns, verbs, and leaving out the little grammatical words like "g," "is," "in." That's called a grammatism or telegraphic speech.
Like sending a telegram back to the gate, "Wife go hospital."
Exactly like that. In severe cases, they might be mute initially or only manage single words. Articulation can be clumsy, dysarthric, and they might make inconsistent sound errors, phonemic paraphasias.
What about naming and understanding?
Naming is usually impaired, and errors are often phonemic, like spoot for spoon. Comprehension is often described as relatively intact, but that's a bit misleading. They usually do have subtle problems, especially understanding complex grammar. The lion was killed by the tiger. They might struggle with who did what to whom.
Okay.
Repetition is also impaired, sounds agrammatic like their speech. Reading comprehension often mirrors their auditory comprehension issues, especially with syntax. And writing is almost always significantly affected, often mirroring the agrammatism and effortful production of speech.
And are there typical associated signs?
Yes, because Broca's area is near the motor cortex for the right side. You very often see a right hemiparesis weakness on the right side of the body and maybe right hemisensory loss. Apraxia, difficulty with purposeful movements, can also occur, affecting speech, apraxia of speech, or the limbs.
Yeah, emotionally.
Patients with Broca's are often acutely aware of their difficulties, which can lead to significant frustration, sometimes depression.
Where's the damage usually located?
Typically, the lesion involves Broca's area itself, the posterior inferior frontal gyrus, but often extends to adjacent cortex and the underlying white matter. To get the full persistent syndrome, the damage often needs to be larger, involving more of the frontoparietal region, usually in the territory of the upper division of the left middle cerebral artery. MCA.
So a smaller lesion might cause less severe or temporary problems.
Right. A lesion strictly limited to Broca's area might just cause transient mutism or mild dysarthria. The deep white matter connections seem important for the full syndrome.
You mentioned aphthymia earlier. What's that again?
Aphemia is a rarer syndrome. It's characterized by transient muteness after a lesion near Broca's area or the inferior motor strip. The key point is, if writing remains completely normal, it's debatable if it's truly a language disorder, aphasia, or more of a pure motor speech output problem. It can evolve into effortful dysarthric speech.
Okay. Now the flip side, Wernicke aphasia. What's the standout feature there?
Wernicke's is characterized by fluent, effortless speech, sometimes even excessive what we call logorrhea or oppressive speech. And this is the critical part, their auditory comprehension is severely impaired.
So they talk easily but don't understand well.
Exactly. And the speech they produce, while fluent in rhythm, is often empty of meaning. It's typically filled with errors, verbal paraphasias, substituting wrong words like pencil for key, neologisms, made-up words, and it can devolve into incomprehensible jargon.
A word salad sometimes.
That term is sometimes used, yes. Naming is also very poor, often with bizarre word substitutions. And unlike Broca's, where production is worse than comprehension, here comprehension is the major deficit. Repetition is also severely impaired because they don't understand what they're supposed to repeat.
What about reading and writing in Wernicke's?
Reading comprehension is usually very impaired, often paralleling their poor auditory comprehension. They can typically write physically, no weakness usually, but the writing is often similar to their speech. Well-formed letters, but full of paragraphic errors, word substitutions, and spelling mistakes, making it largely meaningless.
Any other neurological signs usually seen with Wernicke's?
Unlike Broca's, major motor or sensory deficits are less common. They might have a right visual field cut, hemianopia, because the lesion can affect optic radiations nearby, but generally, no paralysis.
And behaviorally?
It can be different from Broca's, too. They might seem unaware of their deficits, anosognosia, which can make therapy tricky. Sometimes they can become paranoid or agitated, perhaps because they don't understand why others aren't understanding them. Depression seems less common than in Broca's.
And the lesion location for Wernicke's?
It's typically in the posterior part of the superior temporal gyrus. Wernicke's area itself often extending back into the adjacent parietal lobe and middle temporal gyrus. This area is usually supplied by the inferior division of the left MCA. Neuroimaging studies, like perfusion MRI, often show reduced blood flow here, correlating with comprehension deficits.
Then there was pure word deafness. That sounds very specific.
It is. It's the inability to understand spoken words, even though hearing is perfectly normal for non-speech sounds, like a doorbell. Their own speech is usually normal, and reading and writing are intact.
So they can hear, but can't decode speech sounds.
Exactly. The classic cause is bilateral lesions that effectively cut off Wernicke's area from input from both primary auditory cortices. It's a disconnection syndrome. Sometimes a single, strategically placed left temporal lesion can do it too. They often have some mild paraphasic errors in their own speech as well.
What if both production and comprehension are severely knocked out?
That's global aphasia. It's the most severe form, combining features of Broca's and Wernicke's. Speech is typically non-fluent or mute, comprehension is very poor, and naming, repetition, reading, and writing are all profoundly impaired.
And that implies a large lesion.
Usually, yes. It typically involves a large part of the left parasylvian language zone, Broca's, Wernicke's, and the pathways between them. Often, it's the entire territory of the left MCA. These patients almost always have a dense right hemiparesis, sensory loss, and often a hemianopia.
Is recovery possible?
Some recovery can occur, especially if Wernicke's area itself is somewhat spared initially. Comprehension might improve, and it could evolve into a severe Broca's aphasia. But recovery is often slow and incomplete.
Okay, let's move to conduction aphasia. The hallmark there is poor repetition.
That's the defining feature. Really striking difficulty repeating words and phrases, especially as they get longer or more complex. This is despite having relatively fluent, spontaneous speech, though. That speech often contains phonemic paraphasias, sound errors, and attempts at self-correction.
So they can talk okay-ish, understand well, but just can't repeat.
Pretty much. Auditory comprehension is generally good, naming is usually moderately impaired. It's that disconnect between fluency comprehension and repetition that's key. Reading aloud might show similar errors to repetition, but reading comprehension can be better. Writing is variable.
What's the thinking on the cause, the connection pathway?
The classic theory is a disconnection due to damage to the arcuate fasciculus, the tract connecting Wernicke's and Broca's areas. The idea is comprehension happens, production is possible, but the signal can't get across reliably for repetition.
But it's maybe not that simple.
It seems more complex. Lesions in the superior temporal gyrus or inferior parietal lobe, like the supramarginal gyrus, can also cause it. Some researchers think it might relate more to deficits in auditory short-term memory or phonological processing rather than just a simple pathway interruption. The exact role of the arcuate fasciculus is still debated.
Then there's anomic aphasia. That sounds like it's mostly about word finding.
Exactly. The main problem in anomic aphasia is anomia, difficulty retrieving words, especially nouns. Their speech is otherwise fluent, grammatically correct, but you hear lots of pauses, circumlocutions, the thing you write with for pen, and vague words like thing.
But comprehension and repetition are okay.
Generally, yes. Comprehension, repetition, reading, and writing mechanics are usually intact, although their writing will also show the word-finding pauses and difficulties.
Is it common? And does it pinpoint a specific brain area?
It's very common, perhaps the most common residual deficit after recovery from other aphasias, but because it's common, it's less specific for localization. It can result from lesions in various places in the left hemisphere, like the angular gyrus or temporal lobe, or even be swelled with more diffuse issues like tumors or early Alzheimer's. It's also often seen as a stage of recovery.
Now, the transcortical aphasias, you said repetition is spared in these.
Yes, that's the defining feature. Intact repetition suggests the core language loop. Wernicke's, arcuate fasciculus, Broca's is working. The problem lies in the connections between this core loop and other parts of the cortex involved in thought, intention, and meaning.
And they're often linked to watershed strokes.
Often, yes, because the lesions are in those border zones between major artery territories, which are vulnerable to drops in blood pressure or flow.
What are the types?
3 main ones. Mixed transcortical aphasia is rare, like global aphasia, poor production, poor comprehension, but with preserved repetition, often just echoing echolalia, seen with massive watershed strokes or late dementia. Transcortical motor aphasia resembles Broca's non-fluent, effortful speech, but again, repetition is surprisingly good. Lesions are typically frontal, anterior, or superior to Broca's area, maybe in the supplementary motor area territory, often ACA.
And the third?
Transcortical sensory aphasia. This one resembles Wernicke's fluent paraphasic speech, poor comprehension, poor naming, but with intact repetition. Lesions are usually in the temporoparieto-occipital junction area, posterior to Wernicke's. Can also be seen in dementia.
What about aphasias from damage below the cortex? Subcortical aphasias.
Right. These are defined by the lesion location, basal ganglia, thalamus, deep white matter, rather than just the language pattern. The patterns can be a bit more variable or atypical than the classic cortical syndromes.
Such as?
While left thalamic lesions can sometimes cause a fluent aphasia, maybe a bit like Wernicke's, but perhaps with slightly better comprehension. You might see fluctuating language abilities, maybe linked to the thalamus's role in attention. Lesions in the basal ganglia or internal capsule, especially anteriorly, can cause what's called an anterior subcortical aphasia, dysarthria, reduced fluency, maybe mild comprehension repetition issues. Kind of like Broca's, but often with more prominent dysarthria. Posterior subcortical lesions might resemble Wernicke's more. Large ones can cause a global-like picture.
So they can be harder to classify.
Sometimes, yes. You might suspect a subcortical cause if the aphasia doesn't fit neatly into a cortical box, especially if there's significant dysarthria or hemiparesis alongside it.
Let's switch gears slightly to reading disorders. Pure Alexia without agraphia reading loss, but writing is okay.
Exactly. It's fascinating. They can't read, but they can still write perfectly well. It's like they're linguistically blindfolded. Spoken language comprehension and repetition are usually normal. Naming might be okay, though sometimes color naming is off.
How do they try to read?
Often letter by letter. They sound out words very slowly. They can usually understand words spelled aloud to them.
And the cause?
Typically, a stroke in the left posterior cerebral artery territory. It damages the left visual cortex and often the splenium of the corpus callosum, which connects the two visual cortices. The idea is it disconnects the intact right visual cortex, which sees the left visual field, from the left hemisphere language areas. So visual information about words can't get processed linguistically. Usually comes with a right hemianopia, too.
And Alexia with agraphia.
That's basically acquired illiteracy, loss of both reading and writing ability after having been literate. Oral language, speaking, understanding speech is usually relatively preserved, though speech might be fluent with some errors. Comprehension is often better than reading.
Where's the lesion usually?
Typically involves the left inferior parietal lobule, especially the angular gyrus, often associated with right hemianopia and sometimes elements of Gerstmann syndrome, trouble with calculation, left-right orientation, finger identification, writing.
And writing problems often just come along with other aphasias.
Oh yes, very commonly. We call that aphasic alexia or dyslexia. There are different patterns. We mentioned letter-by-letter reading in pure alexia. There's also deep dyslexia. Severe problems can only read some familiar words, often concrete nouns, makes semantic errors, reads cat as dog, can't read non-words, often seen with severe aphasia.
Okay.
Then phonological dyslexia, trouble reading non-words but better with real words, might make sound-based errors. And surface dyslexia difficulty with irregularly spelled words like yacht, kernel, but okay with regular words and non-words they can sound out. Depends on where the reading process breaks down.
What about writing agraphia? Can that happen alone?
It can happen in isolation pure agraphia with lesions in frontal or parietal areas involved in the motor control or planning of writing. More commonly, it occurs with aphasia, aphasic agraphia, or due to motor problems, apraxia, or visuospatial deficits.
Are there different types, like with Alexia?
Yes, similar patterns exist. Phonological agraphia, trouble writing non-words, deep dysgraphia, better with concrete nouns, verbs, lexical surface dysgraphia, trouble writing irregular words, relies on sounding out.
We focused heavily on the left brain. Does the right hemisphere do anything for language?
It does, although the left is dominant for core functions in most people. A small number of left-handers, and very rarely right-handers crossed aphasia, can have aphasia from right hemisphere damage.
But for most people, what happens with right hemisphere damage?
You might not see classic aphasia, but subtler language changes. A big one is apraxia problems with the emotional tone of language. They might speak in a flat monotone, motor apraxia, or struggle to understand emotional tone in others' voices, sensory apraxia.
So the music of language is affected.
Exactly. And also understanding non-literal language metaphors, jokes, sarcasm, irony. They might get the literal words but miss the implied meaning or humor. Following complex stories or getting the main point can also be difficult. These are pragmatic aspects of communication.
Language issues are also really common in dementia, aren't they?
Yes, definitely. The patterns vary. In Alzheimer's disease, typically memory goes first, but language problems emerge early too, often starting with word-finding difficulties, anomia, and less informative, more concrete speech.
Does it progress?
Yes. As Alzheimer's progresses, the language can start to resemble transcortical sensory, or Wernicke's aphasia, with more errors and comprehension problems. Grammar holds up longer, but eventually degrades too. Reading and writing often decline early. Late stage can lead to mutism. Semantic knowledge, word meanings, often erodes before syntax or phonology.
And then there's primary progressive aphasia, PPA.
Right. PPA is different because the main initial symptom is progressive language loss, without major memory or other cognitive problems at the start, although those usually develop later. Brain imaging might show focal atrophy in left language areas.
Are there different types of PPA?
Yes, 3 main variants. Progressive non-fluent aphasia affects speech production and grammar, looking a bit like Broca's. Semantic dementia is a fluent type with major problems in naming and understanding single word meanings, plus often surface dyslexia. And logopenic progressive aphasia features prominent word-finding trouble and difficulty repeating sentences, though single-word comprehension is better. These variants often link to different underlying pathologies like FTLD or sometimes atypical Alzheimer's.
So if someone presents with aphasia, what's the diagnostic workup look like beyond the bedside exam?
The bedside exam gives the initial impression. For more detail and quantification, we use standardized tests like the Boston Diagnostic Aphasia Examination, BDAE, or the Western Aphasia Battery, WAB. These give a profile of strengths and weaknesses across different language tasks. Specific tests like the Boston Naming Test or Token Test can probe particular functions.
And imaging is key.
Absolutely essential. CT and especially MRI are crucial for visualizing the lesion, its location, size, type. MRI gives better detail, especially for temporal lobe structures or differentiating cortical versus subcortical. Diffusion-weighted MRI is vital for seeing acute strokes very early.
What about EG?
EEG is useful if seizures are suspected as a cause or contributor, like in ictal or postictal aphasia or Landau-Kleffner syndrome in kids. It can also show slowing over a damaged brain area.
Any other tests?
In research, SPECT, PUT, and fMRI help study brain activity during language tasks or recovery. The WADA test, temporarily anesthetizing one hemisphere, or fMRI, can determine language dominance before brain surgery.
We touched on causes, but can we recap the main culprits for aphasia?
Stroke is number 1.
Yeah.
Both ischemic blockage and hemorrhagic bleed. The type of aphasia often maps onto the affected artery territory, MCA divisions, PCA, ACA watersheds for transcortical types. Traumatic brain injury, TBI, is another major cause confusions, hematomas. Brain tumors, both primary and metastatic, usually cause more gradual onset aphasia. Infections like brain abscesses, herpes encephalitis, loves the temporal lobes, TB, syphilis, HIV-related issues too.
And degenerative diseases.
Yes, FTLD causing PPA variants, atypical Alzheimer's causing logopenic PPA. Language can also decline in Parkinson's, corticobasal degeneration, CJD. Even metabolic problems like low sodium or lithium toxicity can cause transient language issues.
Seizures and migraine too.
Yes, seizures can cause temporary aphasia, ictal or postictal. Migraine aura can sometimes include transient aphasia, often Wernicke-like, and rarely it can be psychogenic.
What's the outlook for recovery and rehabilitation?
There's often spontaneous recovery after acute events like stroke, fastest in the first weeks to months, but improvement can continue for years. The type of aphasia can change as recovery happens. Global might become Broca's, Wernicke's might become anomic.
How does the brain recover?
It might involve the right hemisphere compensating or adjacent areas in the left hemisphere taking over. Functional imaging suggests the best recovery happens when function returns to the original left hemisphere language areas.
And therapy helps.
Definitely. Speech-language therapy is critical. Therapists use various techniques: script training, constraint-induced therapy, melodic intonation therapy for some non-fluent types to maximize recovery and teach compensatory strategies. AAC devices are vital for some.
Any medications or other treatments?
Research is ongoing. Some drugs like bromocriptine or memantine have been explored with mixed results so far. Brain stimulation techniques like TMS are also being investigated and show some early promise.
Okay, that's a fantastic overview of aphasia. Let's shift now to the motor speech disorders, dysarthria and apraxia of speech.
Right, so these are problems with the articulation of speech, not the language itself. If you wrote down what they said, the language would be normal, correct words, grammar. It's the clarity and mechanics of production that are off.
So Dysarthria first. What's the core issue there?
Dysarthria is basically slurred or unclear speech due to neuromuscular problems affecting the speech muscles, problems with their strength, speed, range, timing, or accuracy. It mainly distorts consonant sounds.
And it's neurological.
Yes, neurogenic causes problems in the CNS, nerves, neuromuscular junction, or muscles involved in speech, not structural issues like missing teeth. It can affect articulation, voice quality, breathing for speech, and prosody. Complete loss is anarthria.
And like aphasia, different types point to different lesion locations.
Exactly. Analyzing the pattern of dysarthria at the bedside is very helpful for localization. We listen carefully as they repeat sounds, words, sentences.
What are the main types in that Mayo Clinic classification?
Okay, there's flaccid dysarthria from lower motor neuron weakness affecting bulbar muscles. Sounds breathy, hypernasal, consonants are imprecise. Think myasthenia gravis, where it gets worse with fatigue.
Yeah.
Spastic dysarthria from bilateral upper motor neuron damage. Voice sounds strangled, speech is slow, consonants imprecise. Common in pseudobulbar palsy from bilateral strokes or conditions like PLS. There's also a milder unilateral UMN type, often after stroke.
Okay.
Ataxic dysarthria from cerebellar damage. Speech sounds irregular, maybe scanning with equal stress on syllables or with sudden articulatory breakdowns. You hear irregular rhythm on rapid repetition of syllables like P seen in cerebellar strokes, MS degenerations.
What about Parkinson's?
That causes hypokinetic dysarthria, characterized by reduced loudness, monotone pitch, sometimes rapid rushes of speech, imprecise consonants, responds to Parkinson's treatments and specific speech therapy like LSVT-LID.
And involuntary movement disorders.
Those cause hyperkinetic dysarthria. Think Huntington's or dystonia. Speech has variable rate, loudness, timing issues, distorted vowels, maybe sudden stoppages or a harsh voice.
And the mixed types.
Very common. ALS often causes a mixed spastic flaccid type. MS can cause various mixes, like spastic ataxic. Wilson's disease might have a hypokinetic spastic ataxic mix.
How is dysarthria managed?
It depends on the type and cause. Speech therapy focuses on things like muscle strengthening, improving articulation clarity, controlling rate, enhancing prosody. Devices like pacing boards, palatal lifts, voice amplifiers, or AAC systems can help. Sometimes surgery, like for vocal fold issues. For Parkinson's, drugs and DBS can also help speech. Goal is maximizing intelligibility.
Now, apraxia of speech. That's different from dysarthria. How?
Apraxia of speech, AOS, isn't about muscle weakness or slowness. It's a problem with motor planning or programming the sequence of movements for articulation. They know the word, the muscles are strong enough, but they can't reliably coordinate them to say it correctly.
So the control signals are getting mixed up.
Sort of. Consonants are often substituted rather than just distorted. A key feature is inconsistency. They might say a word correctly once, then incorrectly the next time, maybe in a different way. Difficulty increases with longer words and initiating speech.
What are the classic signs of AOS?
4 main things. Effortful, groping articulation, often with visible searching movements and attempts to self-correct. Dysprosody, abnormal rhythm and intonation, inconsistent articulation errors, and difficulty initiating utterances.
Does it happen alone?
Rarely in pure form. It's very often seen alongside Broca's aphasia, given the brain areas involved are close. Writing's usually much better than speech, and comprehension is relatively spared.
Where's the lesion usually thought to be?
Research often points to the left precentral gyrus of the insula, deep in the brain. But Broca's area itself and surrounding motor planning regions are also strongly implicated. There's also a progressive form, primary progressive apraxia of speech, linked to neurodegenerative diseases like FTD. Testing involves things like repeating sound sequences, pataka, or complex words to bring out the inconsistency.
How is that different from oral or buccolingual apraxia?
Oral apraxia is difficulty performing non-speech voluntary movements with the mouth, tongue, lips on command, like pretending to lick an ice cream or whistle. It's an ideomotor apraxia for those muscles, separate from speech itself, though it often co-occurs with AOS and Broca's aphasia.
And aphemia again in the motor speech context.
Here, it's seen as severe motor speech output impairment near muteness, but with intact language, comprehension, reading, writing. It can recover to effortful, non-fluent speech, sometimes sounding dysarthric or like a foreign accent, often linked to lesions near the motor cortex face area. Its exact relationship to severe AOS is debated.
What about that foreign accent syndrome?
That's a rare motor speech disorder, usually after a stroke, often left hemisphere motor areas, where changes in timing, intonation, and articulation make the person sound like they've suddenly developed a foreign accent. It's a form of dysarthria, essentially.
And acquired stuttering.
This develops after brain injury, stroke, TBI, unlike developmental stuttering from childhood. It involves repetitions, prolongations, blocks, can overlap with AOS, but might lack the groping or inconsistency. Important to distinguish from psychogenic stuttering post-injury.
Lastly, the opercular syndrome.
Khwashoggi-Marie syndrome, a severe bilateral paralysis of face, pharynx, larynx muscles due to bilateral lesions in the opercular cortex, overlying the insula, causes profound muteness, anarthria, or inability to phonate. Key feature is automatic voluntary dissociation. They might chew or yawn automatically but can't move those muscles voluntarily on command. Limb movements are usually okay.
Wow. We've covered a huge amount of ground. Aphasia, dysarthria, apraxia. It's incredibly complex how language and speech can break down.
It really is. And understanding these different patterns is just so vital for neurological diagnosis, for localizing lesions, and for appreciating the intricate neural machinery behind communication.
Each disorder gives us clues about how specific brain networks function.
Exactly. It's a window into brain organization, and the field is constantly evolving. Better imaging, deeper understanding of networks, new approaches to rehabilitation.
Which is so important for the people affected by these conditions.
Absolutely. The research directly impacts efforts to improve diagnosis and treatment.
So as we wrap up this deep dive, maybe a final thought for you, our listener. When you consider these incredibly complex brain networks for language and speech, what does the process of recovery, however variable it might be, tell us about the brain's inherent plasticity, its ability to adapt, reorganize, and compensate after injury?
It's a profound question. It really highlights the brain's remarkable resilience. We definitely encourage you to keep exploring these topics in neuroscience and speech-language pathology. There's always more to learn.